Welcome to this clinical review on 08 acute ischemic stroke. In this session, we will explore the critical protocols and life-saving interventions required for managing patients experiencing a stroke. Understanding the pathophysiology and the rapid response required is essential for any healthcare provider. We will be focusing on the urgency of care, diagnostic imaging standards, and the pharmacological and surgical treatments that define modern stroke management. By the end of this presentation, you will have a thorough understanding of the timelines and criteria necessary to improve patient outcomes. Let's begin our detailed analysis of the stroke care pathway. 0 acute ischemic stroke. 8.1 focuses on the time is brain concept, which highlights the extreme urgency of this medical emergency. Stats show that approximately 1.9 million neurons die every minute during a stroke, emphasizing that every second counts for brain preservation. For activation of the stroke team, you must use a stroke scale like the Cincinnati Pre-Hospital Stroke Scale immediately to assess the patient. This scale identifies facial droop by asking the patient to smile. It also checks for arm drift by having the patient hold their arms out with eyes closed. Finally, it assesses abnormal speech by listening for slurring or incorrect words. Acute ischemic stroke 8.2 outlines the stroke timeline, which sets strict benchmarks for hospital efficiency. The door-to-physician goal is 10 minutes, meaning a doctor must evaluate the patient shortly after arrival. The door-to-CT scan goal is 20 minutes, ensuring rapid imaging to determine the stroke type. The door-to-CT interpretation goal is 45 minutes, requiring a radiologist to read the scans quickly. Finally, the door-to-fibrinolytics goal is 60 minutes, which is the target for adjusting medication to eligible patients. These time-sensitive steps are vital for maximizing the chances of recovery and reducing long-term disability. Acute ischemic stroke 8.3 covers imaging and diagnosis, where the non-contrast CT scan is established as the first and most critical test in the emergency department. The primary goal of this initial imaging is to rule out hemorrhagic stroke, which involves identifying any active bleeding within the brain tissue. If the CT scan shows that there is no blood, the clinical team can conclude that the stroke is likely ischemic, meaning it is caused by a clot. This distinction is fundamental because the treatment for a clot-based stroke is dangerous and counterindicated if the patient is actually experiencing a brain bleed. 08 ischemic stroke 8.4 details fibrinolytic therapy using TPA or TNK. The criteria for administration require that the treatment must be within 3 to 4.5 hours of the last known well time. There are strict exclusion criteria, such as recent surgery, active bleeding, or very high blood pressure exceeding 185/110, which increase the risk of complications. Continuous monitoring is mandatory after administration to watch for signs of intracranial hemorrhage. Providers must be vigilant for symptoms like a sudden severe headache or a worsening neurological status, as these indicate a life-threatening transition from an ischemic stroke to a hemorrhagic one. 8.5 discusses endovascular therapy, or EVT. Mechanical thrombectomy is a specialized procedure using a catheter to manually remove a large clot from the cerebral arteries. The window for this intervention is significantly longer than chemical treatments, as it can be performed up to 24 hours after symptom onset for certain patients. This is specifically indicated for large vessel occlusions, known as LVOs, where a major artery is blocked. This advanced surgical option provides a critical secondary treatment path for patients who may have missed the fibrinolytic window or who have clots too large to be dissolved by medication alone.